Veglekar sir, Dr. Sachin Deva sir, Assistant Professor Dr. Mohammed Hanif Said sir, and other exclusively related respected fraternity. Let us start the program with a Dhanvantari Vandana by Dr. Avani Sankhani, the PG Scholar of Department of Ayurveda, PIA.
सुप्रभातम्
Please.
गरिमादिदेवं सुरासुरेवन्दितपादपद्मं लोके जलायुक्भयनोऽतुनाशं दातामीशं विविधोषधीनाम्
Special thanks to Dr. Avani. Here we will have an online session on his esteemed presence of Professor Subhash Vaghesar, President RVPGA, Rognidan Vigyan Association, PT Association for Pathology and Radio Diagnosis. As you all know, today, 20th of July, we are observing World Hepatitis Day, which is the birthday of Nobel Prize winning American scientist geneticist Dr. Baruch Samuel Bloomberg, who discovered hepatitis B virus and developed diagnostic test and vaccine for the same. It is organized worldwide to increase the awareness against viral hepatitis. The theme this year is One Life, One Liver. Every year, 1 million deaths are reported, and in every 30 seconds, a person dies affected by liver-related diseases. We are here uniting for a hepatitis-free agenda meant for viral hepatitis elimination, which being a major public health concern. As we mentioned earlier, Professor Subhash Vaghesar delivered the most informative speech on the topic Concept of Cirrhosis in Ayurveda and its management, who is very well known to the Ayurvedic fraternity, and that his scholastic personality does not require any special introduction. We all are aware how much contribution he has done so far and imparted to the system. But I take it a liberty to mention some of his achievements in the field of Ayurveda. He had his UG education from Government Ayurvedic College, Nagpur, PG in Rognedan from Sri Ayurvedic College, Nagpur, currently PhD scholar of MUHS and professor at SRK Ayurvedic College, Bhopal, Madhya Pradesh. He has 20 Ayurvedic books on his own, wrote more than 50 research articles published in ISSN journals. He has been awarded the Best Book of the Year in Pune. He was awarded the prestigious Vaidya Yadavji Trigamji Granth Puraskara in Pune. Moreover, Dhanvantari Award, Best Global Teacher Award, Best Researcher Award, 2 Best Paper Awards are on his credit. He has revived 8 lost Samhidas of Ayurveda and was felicitated at Latur by Ayurveda Update Group for the same. He has been on the editorial board of many national and international journals. He presented many research papers in various national and international conferences. He was a member of the team for framing Nidan Dictionary by Government of India. He has invited as the resource person to many national and international seminars and conferences and took lectures for international delegates of Brazil, Portugal, and Russia. Presently, he is the president of RVPGA organization, editor-in-chief of IJDR, International Journal of Diagnostics and Research Journal, and editor-in-chief of RVPGA International Publishers India. Both are the brilliant initiatives of RVPGA. We are gratefully obliged and thankful to you, sir, for having agreed to present the topic at a short notice. Also, I take this opportunity to extend our thanks and regards for favoring us and our institution with your valuable sign and logo of RVPGA, IJDR, and RVPGA International Publishers India. Before starting the session, I would like to say a few words about RVPGA. Without this, the session is incomplete, and I won't take much time, sir. RVPGA was formed in the year of 2016 under the able and dynamic leadership of Dr. Subhash Vaghesar with the aim to give the legal status of pathologist and radiologists to the PGs of Roghudan. It is the only organization which is fighting for the lawful rights of Rogvedana PGs. Even the NCSM had also directed State of Maharashtra to consider RVPGA as a stakeholder in the constitution of pathology regulatory body of the state. The organization is also constantly trying for the implementation of NCSM salary structure in all the private Ayurvedic colleges across the nation. Once again, I earnestly invite all the participants to enjoy this illuminating session. With immense pleasure, I kindly request Professor Subhash Varghese sir to commence the lecture. Please, sir.
Thank you very much, dear Anne Madam, for precisely introducing me and our organization, RVPJ. It's been a wonderful morning, and I'm very much happy to see you all pleasant faces here, and all my friends there in Parul. I think the global impact of the disease is already mentioned by my friend Dr. Anne, and I would like to go to the straight away go to the disease. As she told, the global 2.5% deaths are due to the chronic liver disease. But before we start the chronic disease, we must know the acute phase also, because only it is only the acute phase which leads to the chronic phase. And before even acute phase, it is the normal physiology which gets disturbed, and because of that not disturbance in normal physiology, this the whole pathology occurs. That's because shall I make my window full screen?
Yes, sir. Please proceed.
Full screen. How to do it? Okay. Am I audible loud and clear to everyone?
Audible, sir? Just share your
Oh,
PPT, sir.
no,
Everything
okay.
is okay.
Before sharing the PPT, just because I think this lecture is arranged for PG students and
Yes.
other students, and most of them are here. Here are the students. So I will deliver my talk according to their need, and keeping them in my view, so
Sure,
that
sir.
they get the proper idea of the subject and they understand the thing once for and all, and their ideas are clear both from modern point of view and the Ayurvedic point of view.
Yes, sir.
Okay. So, friends, something the few lines about the bilirubin metabolism. As you know, the fragile RBCs, they get destroyed in the hepatic circulation while traveling through in the, and the albumin globulin complex breaks, and then this I mean, the albumin plus globulin, and from globulin, then bilirubin, biliverdin, etc. And from in the hepatocytes itself, the liberated bilirubin is conjugated with the glucuronic acid. Then again, it is secreted into the bile canaliculi, and bile canaliculi, the canaliculi joins together to form the hepatic duct, and from gallbladder, it continues as a common bile duct, and it opens in the intestine, and it secretes the bile there, which is containing conjugated bilirubin, and this is acted upon by the intestinal bacteria to convert it into urobilinogen, which is again water soluble highly, and gets diffused into the urine, and these some of the urobilinogen is oxidized into stercobilinogen, which gives the typical yellow color to the stool. Now, this is so far is the physiological aspect. Once you clear these physiological aspects, it becomes very easy to understand the pathology. Now then, so friends, liver, as you take, it performs many functions: lipid metabolism, fat metabolism, protein metabolism, detoxification. You all know, you have all read those functions. Why it is important? Because in coming subsequent things, you should know these functions. Because if the liver is deranged by anything, if the injury happens to the liver, these all function gets disturbed. As these all functions get disturbed, as the normal physiology is disturbed, the pathology appears. See, what are the causes which causes liver injury? No, there are some microbial causes, for example, viruses, bacteria, protozoas, and the most hepatophilic viruses are HIV, HBV, HCV, HDV, HEV, and Epstein-Barr virus, etc. Toxins such as you can consider alcohol, the most prominent one, then carbon tetrachloride and the anti-tubercular drugs. Uh, these are the commonest things which can cause liver injury. But mostly we notice that it is the hepatophilic viruses and the alcohol which is responsible for the uh, hepatic injury. Now, how they cause, how they cause it. So, as you know, whenever any bacterial viral invasion occurs or any toxic agent goes, then there is a fighting from the body host response. It produces an inflammatory reaction, and inflammation causes edema to the hepatic cells. As the hepatocytes are swollen, what will happen? As the hepatocytes are swollen, they put pressure on the bile canaliculi in between, and moreover the lymphocytes which come for the defense mechanism, they also get sludge there, and it causes the sludging there, deposition there, and the whole bile canalicle is entire in the gross architecture of the liver gets blocked, so that the bile doesn't flow below in the hepatic duct, and it doesn't come in the gastrointestinal tract. This is called as intrahepatic cholestasis. This is intrahepatic cholestasis because of the acute hepatic injury due to such agents. There is one another form of extrahepatic cholestasis, wherein the common bile duct is get blocked because of stricture, atresia, or any compressing tumor. That is another thing. But we will focus on this today on this acute and acute hepatic injury and chronic hepatic injury. I suppose you are getting me. Now, if the liver is swollen and the bile is not coming into the uh, gut, the constitutional features of viremia appears. Anorexia, that is loss of appetite, malaise, vomiting. So that body creates some symptoms that you should not eat. I'm not hungry because of loss of appetite. And as the bile is not coming into the GI tract, it doesn't stains the stool as yellow and stool becomes pale. This is how the course. Now, as with any viral illnesses, they are self-limiting. Body produces antibodies, and after some time, say this whether you give something or not, in most of the cases, almost 99% of the cases, there is full recovery, and in some 1%, the acute phase may also cause acute fulminant hepatic failure, or some 1 to 2% cases they may go they may go chronic active hepatitis and then the chronic sequelae. But see, in most of the patients, the recovery occurs in within 3 weeks. In first week, there are features of viremia, as like flu-like symptoms are there. There is sneezing, there is coughing, then loss of appetite, malaise, vomiting, all these things. Severe anorexia is the classical feature of this acute hepatitis. After that, in second week, in the first week, icterus doesn't appear. In second week, little bit hepatomegaly appears, and eye starts yellowing. In the third week, icterus deepens, but appetite returns to normal. Hepatomegaly further grows, but and by the third to fourth week, everything comes down and everything is normal. But you may feel hepatomegaly for 3 months even after the illness is over. The gradual resolution comes because the necrotic material and all the debris body takes times to eat and clear it, the, the entire that pathology by the macrophages. Now, this is why this is important. Oh, because now you have understood the proper physiology of the biliary mechanism, and because of that you are now able to understand the hepatic insult, hepatic injury, and the its sequelae, how it occurs. Now, so in some patients, as you know, these hepatitis A virus, E virus, they are fecal-oral, they are transmitted by fecal-oral route, and HBV, HCV, they are by the parental route. Now, this B virus and C virus, in some individuals where the immunity is compromised, in those individuals, this acute hepatitis becomes the chronic active hepatitis, and then at later it leads to the cirrhosis. So the main causes of cirrhosis are hepatitis, chronic hepatitis B virus infection, hepatitis C virus infection, and the chronic insult due to alcohol. If anyone take alcohol daily, see, alcohol is the cause of hepatic injury, that is mentioned in some time immortal, that is mentioned in our science also. But 1 in 10,000 only gets cirrhosis. There is so the chances of getting cirrhosis due to alcohol is very less. Uh, even if consumes it 90 ml after 3 days gap, then there is no problem. But if one takes 30 ml even daily, that may cause problem. The daily that causes because once alcohol is consumed, that the clearance takes place for 3 days from the body by the hepatocytes. But if the insult is continued again and again, again and again and again and again, then these necrosis. So what I was telling, the causes of cirrhosis: HBV, HCV infection, alcohol, and third one is the fatty infiltration of the liver in obese patients, obese individuals. So the first, the fatty necrosis, and in case of alcoholic and fatty infiltration, and direct hepatic necrosis due to toxicity and the inflammatory reaction in case of viruses. So the necrosis of hepatic cells followed by fibrosis, because body tries to defend the things, but when the insult is repeated, the whole the filamentous structure collapse and the tendency to form fibers is increased and fibrosis occurs, followed by the nodule formation. So small nodules in uh, alcoholic and big nodules in post-viral cirrhosis. Other causes, if you see the other causes of cirrhosis, those are alpha-1 antitrypsin deficiency, galactosemia, Budd-Chiari syndrome, that is hepatic vein thrombosis, then Wilson's disease, that is excessive copper deposition in the body, hemochromatosis, that is excessive deposition of iron in the body. These are some secondary causes. They occur very rarely. So for rare causes, you need not to concentrate so much. Let's focus on this one only. Now, these are the causes as I enumerated. And clinically, what clinical syndrome they produce and after the pathology. Now, as I have said to you, because of the gross derangement in the liver gets, because of the fibrosis, liver gets, initially there is hepatomegaly, and after that it shrinks, and it offers resistance to the flow of portal veins. The portal veins collecting all the nutrition from the gut, and it supplies to the liver for further metabolization, then through IVC to the heart and entire body. So this is the normal physiology. But now, as the liver is offering a resistance to the flow of portal veins, so what will happen? The flow will go back. Flow will go back, and the local hydrostatic pressure will raise. And as the flow will grow back, the congestion will occur in the entire gut. That typical portal hypertensive gastropathy occurs. The congestion occurs everywhere in the gut, and the congestion occurs in the spleen also. That's why there is splenomegaly. Okay, and as you know, now the first is the splenomegaly is occurring. The second, the hydrostatic pressure is increasing. And now, as I have said to you, that one of the function of the liver is the protein metabolism. Now, as the proteins are not formed, there is hypoproteinemia. Our blood flows in a laminar fashion. Idhar udhar jata nahi. It doesn't seeps in you from the blood vessel because of there is a lateral colloidal pressure from the proteins, which arrests uh, the seepage. But now, as the proteins are less formed in the body, there is hyperproteinemia, there is less plasma osmotic pressure, and there is no one to stop the blood from oozing, and the local hydrostatic pressure is increased. The net movement of the fluid occurs in the peritoneal cavity, and the collection of fluid in the peritoneal cavity results in the ascites, jalodhara. So ascites, splenomegaly, and ascites. The first two complications we are going through the features and complications of the cirrhosis of liver now. So this the constitutional features will be same: malaise, anorexia, etc., weakness, those feelings. Now we are coming to the compensated and decompensated features of the cirrhosis of liver. In the now we have seen splenomegaly, second is ascites, how ascites form. Now further, but body is the best physician, and body tries to correct itself. As the pressure in the portals is increased, body tries to depressurize it by forming the collaterals with the systemic circulation, and the compliant venous system dilates so that it gets anastomized with the systemic circulation. And the site where this anastomosis occurs, they are retroperitoneum, around umbilicus, uh, near rectum, and gastroesophageal junction. These anastomoses are called as varices. So the rectal varices, umbilical varices, retroperitoneal varices, gastroesophageal junction varices. But since this out of this varices, the gastroesophageal junction varices, which is placed superficially and under abnormally high pressure. The rest of the varices, they are deep in the musculature, whereas these gastroesophageal junction varices, they are superficial in nature and under abnormally high pressure. Hence, they tends to bleed. So, some 10 to 15% patients, they have a tendency to bleed. So, what the physician do nowadays, whenever he suspect a patient of chronic liver injury, or he carries out explorative endoscopy, GI endoscopy, and if he finds the varices there itself he carries out the band ligation of the varices, and the overt risk of hematemesis is avoided nowadays, and that is very good thing. So uh, the fourth complication we are noticing is of the varices and the resulting hematemesis. And the same hematemesis, when the same blood when comes out after metabolization in the gut with the stools, black, that results in black tarry stools, that is referred as malina, krishna shakrut. Okay. Now, as a complication, you see, as the system anastomosis with the systemic circulation had taken place, the toxic metabolites which were supposed to go to the liver for detoxification now gets ammonia, mercaptans, all those toxic metabolites get direct entry into the systemic circulation. After getting entry into the systemic circulation, they crosses the blood-brain barrier and precipitates the encephalopathy. Pathy means disease, apathy. So they precipitates encephalopathy, which may show features like drowsiness, semi-coma. Ultimately, patient lands in coma, stupor, like this, like in some phases. So ऐसे पेशेंट में हम क्या करते हैं जिसमें हमको डाउट है कि ये पेशेंट दिस पेशेंट कैन लैंड इन एंसेफेलोपैथी, उसको रोज एक कागज में रोज हैंडराइटिंग से लिखने का, और जिस दिन हैंडराइटिंग में फर्क पड़ता है उस दिन हॉस्पिटल में आ जाने का. कॉन्स्टिट्यूशनल अप्रैक्सिया, writing gets affected. The moment the writing gets affected, he should get hospitalized, and in hospital we give enema, and through enema the weak purgative like lactulose is administered, which limits the absorption of ammonia in the gut. Again, the complication of hepatopulmonary syndrome can occur wherein the pulmonary vessels they dilate and results in breathlessness, dyspnea, halitosis. Uh, Again, hepatorenal syndrome also occurs wherein the flow is directed away from the renal uh, architecture, because of this complex mechanism, and resulting in reduced GFR, glomerular filtration rate, and these oliguria and etc. can result the kidney injury. So these are the complications which can take place with this uh, chronic liver injury. I think as far as this much of the portion is, whatever I told, you have understood. So coming to the investigation part, the whenever I ask the students, "Okay, what is the liver function test?" They start telling uh, bilirubin, SGOT, SGPT, then serum proteins, prothrombin time. But I tell you friends, the real left liver function test is serum proteins and the prothrombin time, because proteins they are the marker of synthetic function of the liver. Liver synthesizes proteins, and all the clotting factors except fourth and sixth. Uh, the prothrombin is a clotting factor. As the as there is hepatic function is altered, so what will happen? Now, serum bilirubin, mostly in hepatocellular jaundice, mostly conjugated hyperbilirubinemia with there. We need to differentiate it from hemolytic jaundice, wherein there is unconjugated bilirubinemia and there is no obstruction anywhere in the biliary tract. But here you will find the conjugated hyperbilirubinemia. But in case of cirrhosis, these levels may not be that much raised as like acute phase. It may be somewhere around 2.5 mg per deciliter. Then SGOT, SGPT, the SGPT is the cytosol enzyme, SGOT being the mitochondrial enzyme. And as the hepatocyte breaks, the contents of the cytoplasm that gets leaks into the systemic circulation, and this SGOT, SGPT, the level of this SGPT and SGPT, which are the hepatocyte enzymes, also get increased in the body, and accordingly we get 5 to 50 international unit per liter is the normal range, and it may raise up to more than 500 also. So AP is the alkaline phosphatase raises when there is extra hepatic obstruction, and we may require some taste, particularly when the secondary causes uh, are suspected. For example, as I told, they are very rare and will not focus that much on them. But even then, if you suspect Wilson disease, that is excessive copper deposition, then serum copper and ceruloplasmin is done. alpha 1 antitrypsin. This thing can also be assessed, uh, and serum iron, serum ferritin for if the hemochromatosis is suspected, alpha fetoproteins if the hepatocellular carcinoma. That's one thing I forgotten to tell you, that in the one more complication that of this viral cirrhosis is that the hepatitis B virus, particularly hepatitis C virus, the core E antigen may get a malignant transformation, and when that occurs, it leads to development of hepatocellular carcinoma. So in that condition, alpha fetoprotein is the test of choice, cancer marker, hepatic cancer marker, that is. Nowadays, there is a test to measure the amount of fibrosis in the liver also, and the prothrombin time is prolonged. If there is more than 3 seconds difference between patients and control, it is said to be increased. INR we need to check more than 1.1, again suggests the hepatic injury. These are you see, if you conduct CBC, there will be low hemoglobin, as is also protein, and there will be leukopenia. Okay, these are the things. Apart from this, we can do ultrasonography to know the gross liver architecture, even MRCP, magnetic resonance cholangiopancreatography. This, and again endoscopy to rule out the uh, varices, and received I think ascitic fluid tapping for to know the transitive or exudative pathology. If the proteins are less than 1 gram percentage, it is a transitive pathology. If it is more than 1 gram percentage, it is the exudative pathology from causes like tuberculosis ascites. And we can one more SAG, serum albumin and serum ascitic albumin. We can get their subtraction, and SAG ratio we can do for knowing the things more than, if it is more than 1.1 gram, less than 1.1 gram percentage. It's again, I mean, transitive. So these ascites also, there's we can also carry out some of the tests to see if the cells are increased, whether it is one more complication can occur, that is subacute bacterial peritonitis. In that case, cells are increased, and if it's ascites due to pancreas, then the ascitic amylase is increased. We can subject is for Jill Nielsen and gram staining also. So accordingly, we can infer about the underlying things, but mostly 95%, 98% of the time, ascites is due to chronic liver injury, mind well, and 1% is due to cardiac events as like CCF, and 1% due to renal failure. But majority of 98% of the time, ascites is due to liver injury. How do we manage ascites here? We restrict the water intake. We institute potassium sparing diuretics to reduce the chances of hypokalemia, like spironolactone, and the acidic tapping at the regular instances. And overall, the patient is managed. Patient is given the almost daily 15-gram proteins, and because as it is he is malnourished, and you need to do symptomatic treatment. For example, if the varices are noticed, the band ligation should be there. Then hematomasis and severe if blood loss is there, we can give the blood transfusion. This is all symptomatic management is there. And for ascites, as I have told, and for preventing the hepatic encephalopathy, we give the weak purgative like lactulose, and we limit the absorption of the ammonia from the gut. There how we manage the patient. Now, having said all this about the modern aspects of the liver, cirrhosis of the liver, now coming to the Ayurvedic aspect, how this disease has been mentioned in our science. In our science, the jaundice is referred as kamla, kaman lati hanti, wherein there is aversion of all desires of the air. And you see, after Pandu, when uh, when uh, basically three types of kamla are mentioned: Koshta Shakashrit Kamla, and the Koshtashrit Kamla. Koshtashrit Kamla is nothing but the Kumbha Kamla, which is the chronic stage of the Koshta Shakashrit Kamla. So many people they may get confused or as to what this Shakashrit, what this Koshtashrit, what this Koshta Shakashrit, and all this. Why acharyas have classified it like that. So while mentioning the Samprapti pathogenesis of Kamla, acharyas have mentioned पांडुरोगोति यत् यः तु पित्तलानि निशवते तस्य पित्तम् असृग्मासं दग्ध्वा रोगाय कल्पते. So this pathology can occur with pre-existing anemia. Acharya Sushruti and Vagbota said अन्य रोगादृते अपि ह्यामायन्ते. It can occur without the pre-existent anemia because of other diseases also. We will take those, and in Shakashrit Kamla also they have mentioned that if left untreated, this can also lead to the chronicity. So we will take Shakashrit also here. So the complication of all these things with pre-existent anemia, without pre-existent anemia, and the plain hepatitis, Shakashrit Kamla, they all can lead to the Koshtashrit Kamla. What is Koshta and Shaka? Why they are classified like this? When the Kamla is reflected in the Shakas, when the yellowishness, jaundicness, the yellowishness is reflected in shakhas like Rasirakta, Daya, Dhatva, Takchedar, they are the shakhas. In sclera, nail beds, skin, when it is reflected in shakhas, it is called Shaka Kamla. No, this conjugated bilirubin is water soluble, and it is when there is intrahepatic cholestasis, it gets diffused into the blood, and thereby there is yellowishness, there is yellowish hue to the body and heavily purpose tissues like eyes, nail beds, etc., and skin. That is, this is Shakashrit. But when after some time, when the intrahepatic cholestasis, the pressure is relieved and the bile starts returning to the gut, it starts staining the stool, then it is Koshta and Shakhashrit. It becomes Koshta and Shakhashrit. When the illness is completely over, then there is no more Shakhashrit Kamla. And if it takes the form of chronic active hepatitis, it gets reflected in the Koshta only, and it becomes कोष्ठाश्रित only. कालांतरात खरी वृद्धा कृच्छास्यात कुंभकामला और उपेक्षाची शोफाढ्या कुंभकामला. It is also that Koshtashrit Kamla is also referred as the Kumbha Kamla. Uh, you see, the acharyas use the typical terminology, giving the clue for pathogenesis. Kalantar khari bhuta krichasa Kumbha Kamla. Why it should be referred to the hepatocytes? You see, the sthana of Ranjak Pitta has been told as Ekruta in the liver, Ekruta in the Ayurveda. Okay, and there is Ashrashi Sambandha of Ekruta and the Pitta, and one of the function of the Pitta is the process of inflammation. Pallor, calor, dolor, and this Shot, Koth, etc. are the functions of Pitta. It brings out the necrosis when there is a Dagdva pathology. So in Pando, they have used the terminology Pradushya Rakta. Vyamam, Amlam, Madhyam, Brudam, Divasapno, Atiyotisham, Nisho, Manasya, Pradushya Raktam, Dosha, Adastacham, Pandurtam, Nanti. Here the word is Pradushya. Now the next subsequent pathology is यदा तो पांडुरोंगि पित्तलानि निशोधे तस्य पित्तम असृग मांसम दग्ध्वा रोगाय कल्पते. तस्य पित्तम. Here, pitta is causing the problem. Pitta tasya pitta asrug mansam dagdva. Now, asrug dagdva leads to the hemolytic pathology that causes when the pathology is predominantly asrug dagdva, that is hemolytic jaundice, and when the predominant pathology is mans dagdva, which causes hepatolysis. Mans dagdva refers to hepatolysis because there is ashra ashtra sambandha of the liver and the pitta. Unless the liver is involved, how one will get the jaundice? Simple thing to answer. Now, take it, understand it properly once for and all. It will clear your ideas. Tasya pitram astrug mansam dagdva roga kalpa. Now, dagdva. So, if you put something on boiling, say for one decoction you have put on the boiling, now it is burning. They have used the terminology which was prevailing in those days. Say for necrosis, they have used, now it starts necrosings, they use dagdva. Now, if you keep on burning it, what will it will in our science there is mrudu, madhyam, and kharapaka. So kharapaka stage to indicate the fibrosis in liver, they have used the terminology kalantarat kharibhuta. Kharibhuta kruchasyat kumbhakamla. This kharibhuta refers to the fibrosis, and they have described the entire syndrome of cirrhosis of liver. What? Sarakta chardi, hematomasis, krishna shakrut, malina, nashta sangya. Nashta sangya is encephalopathy. All the features of portal hypertension you are getting. Pliha viruddhya jatram jatra chopaha. Pliha vriddhi, splenomegaly leads to pliha viruddhya pliha vriddhi, pliha viruddhya jatram jatra chopaha. Pliha splenomegaly leads to ascites, and ascites leads to edema. Those things are scattered, we can bring together. Mahan shopha tatra, kumbhasavaha. So Mahan shopha and shunmushkodara. Shunmushkodara is the ascites involving the genitalia. That is huge ascites that can occur only in cirrhosis of liver, dear friends. So, in nutshell, the entire syndrome of cirrhosis of his liver is very well described there, and the features of chronic liver disease are mentioned there. The next advanced pathology is halimaka, where in chronicity, some of the bilirubin pigments they get oxidized into green color biliverdin, and that's how we get the greenish hue in the patients of halimaka. यदा तो पांडव हरित चाव पीता कहा स्त्रीषु हर्षो loss of libido because of estrogen level is increased in cirrhosis of liver. That's why they get gynecomastia. So these are the advanced stages. Kamla, Kumbha Kamla, Halimaka, they are advanced. One more is Panki, wherein the Apan Vayu is vitiated, and that's why it leads to the Santapo Bhinna Varchastu, loose motions. When that occurs, that stage is of Panki. Lagrakam or Lodrakam, where the patients Ludati iti Lodram, when there is mental confusions and patient gets drowsy frequently, that condition is, but that hepatoencephalopathy condition is a Lodrakam. I suppose you have got the point. Now, to let you know the management of cirrhosis of liver in Ayurveda, I will be just show I will be sharing the PPT for this uh, management of complications of the this thing. Just a minute. Is that coming? Yes. think it's not coming. It's not coming. Okay, leave it. It's not coming. I will take. No, as far as treating the complications of cirrhosis of liver is concerned, the management of ascites, the Acharya has told that first thing Acharya has told, you see, toya varjanam means restriction of water. Another thing is lavan varjita ahar, salt and water. They see how the scientific approach is there. Lavan varjita ahar, because salt causes water retention. It will further aggravate the acidic conditions and water content of the body. So, uh, the water restriction, salt restriction, and the acidic tapping at regular intervals at Acharya's store. And that acidic tapping is also scientifically mentioned. They have mentioned that if you remove the entire water in a day, it will patient either may collapse or it will refills again, and that happens. That's why at the first, third, fifth, this odd days they have mentioned to systematically remove the acidic tapping so that patient gets little bit relief from respiratory distress. And ideally, why you should not remove it in one sitting. And very important to note the complications of tapping, as mentioned. Hemoperitoneum may occur, and after that, the oozing may not stop. If it doesn't stop, Acharya said, carry out the cleaning and dressing of the wound. If it doesn't stop with that, also sieve the wound. If it doesn't stop with that, carry out the Agni Karma, cauterization. So, mm, this, this, even today, this is followed. If at all the oozing is not arrested, and for the coagulopathy, which we notice in cirrhosis of liver, sthanatva pitta ka, whenever in rakta pitta it is mentioned, and in that chapter also very in the beginning, the raktava srotas mulanam yakrutpliyanam, they are mentioned. And when this doesn't stop, स्थानात्वरहितम अस्कंदी जमता नहीं है, as there is a coagulopathy, थोड़ा सा भी कुछ हुआ तो ecchymosis, easy bruising and bleeding occurs. So अगर प्रोफ्यूज ब्लीडिंग हुआ तो उन्होंने कहा कि रक्त बस्ती दो, जिसमें गोट के रक्त को लीवर के साथ बारीक से मेश करके उसका रक्त बस्ती दो. That was crude way of blood transfusion in that time, but the idea is same. वृद्धि समाने ही सर्वेशम, ब्लड गया तो ब्लड दो, जल गया तो जल दो. That is the principle. And they have mentioned so many measures for arresting the measures and the compounds for arresting the bleeding. For encephalopathy in Kamla, they have asked to carry out the Mridu Virechana. That is one way we can do it. Rest is the other symptomatic management is there. So I suppose you have got fair enough idea of the disease condition which I have which the topic was given to me, and we can take some questions, or we can carry forward also.
Thank you so much, sir, for this valuable and informative session and the topic most significant of the day. And we are looking forward to further collaboration and cooperation with you, sir. There is some questions in the chat box, sir. Chat box. It is asked that the question is from Dr. Nancy Vakhasia. It is asked that what is the relationship between cirrhosis and renal dysfunction, and how can hepatorenal syndrome be effectively managed?
Okay, it's a good question. You see what, because of the endotoxemia and the overt NCIDs and all these prostaglandins, etc., the flow is directed away from the renal vasculature. जो किडनी है वो उसकी तरफ फ्लो नहीं जाते। देखिए हमारे हर बॉडी के हर अवयव को रक्त के माध्यम से ऑक्सीजन और न्यूट्रिशन प्रोवाइड किया जाता है। अब जब ये नहीं होता है तो उस ऑर्गन के सेल्स की डेथ होने नेक्रोसिस के और डेथ होने लगती है इश्चेमिक इंसल्ट होने से। जैसा कि इसमें ये एंडोटॉक्सिमिया के कारण रीनल वास्कुलेचर यानी जो रीनल ब्लड वेसल्स है उसकी तरफ ब्लड फ्लो रिड्यूस हो जाता है, जाता नहीं है, और रिड्यूस ग्लोमेरुलर फिल्ट्रेशन रेट हो जाता है। तो जब रिड्यूस ब्लड फ्लो होने लगता है तो किडनी की सेल्स डेड होने लगती है। So that's why the condition of renal failure ensues in these conditions. So कैसे मैनेज किया जाता है? अब ऐसे अगर बिल्कुल ही एन्यूरिक होने लग गया है पेशेंट, यूरिन नहीं आ रही है, हाइपोटेंशन है, ये सब इस कंडीशन में फिर हम उसको डोपामिन ड्रिप वगैरह जो है वो लगाते हैं। दैट इज़ द पार्ट ऑफ द मैनेजमेंट।
Yes, sir. Thank you so much. The next question from Dr. Gyati Shukla. What is the impact of cirrhosis on mental health, and how can healthcare providers address the emotional well-being of affected individuals?
Uh, Good question, because you see there is always a likely possibility of a patient landing into the hepatic encephalopathy. So patient always fear that whether when I will land in encephalopathy, because doctor tells that हर दिन आप एक चैप्टर लिखा करो बुक में, और जब भी वो हैंडराइटिंग में लिखावट में फ़र्क आ जाए तो उस दिन हॉस्पिटलाइज हो जाओ, तो फिर हम आपको इनिमा देंगे, इनिमा के माध्यम से उसका जो अमोनिया एब्सॉर्प्शन है बॉडी में वो लिमिट करेंगे और पेशेंट को थोड़ा ओके कंडीशन में फिर ओके करेंगे। तो पेशेंट को एक को फियर रहती है, तो उसका वे एक ही है कि जो हमने ये प्रोफिलैक्टिकली बताया कि यू नॉट टू वरी अबाउट। जब आप कॉन्स्टिट्यूशनल अप्रेक्सिया नोटिस करेंगे तो आप हॉस्पिटल में जाइए, आप जो कंडीशन है उसको एक्सेप्ट कीजिए, और सिंस वी कैनॉट रिवर्स इट, बट if we can know, if we know the condition very well, और उसको हमने वो कंडीशन को जानते हुए उसके बारे में केयर किया, तो हम बच सकते हैं। सो एवरेज सर्वाइवल रेट once after detection is in 50% individuals is 5 years.
Yes, sir. Sir,
So
thank you, sir. There is one more question from Dr. Nishant Patel. It is asked that is milk is advisable in severe jaundice with ascites? Many controversial concepts are there related to milk and jaundice.
yeah, in what juice can be given?
Milk, sir.
Milk, you see, initially, to avoid the protein burden, as the liver is compromised, to avoid the protein burden, milk is restricted, but juice contains the ready calories, and mostly we provide the calories even in the form of IV fluids. The juice is advocated, no problem. And in chronic phase, because there is malnutrition and proteins are not provided, then you have to supplement the milk also given, because for chronic you see, one of the management of the cirrhosis, the dugdahar is suggested in Ayurveda. For complete 1 year the patient is put on the dugdahar, that to camel milk. So it provides the necessary proteins also and other things. The milk is considered as a complete diet.
Thank you so much, sir. If anyone is having any query or doubt, you can put it in the chat box or feel free to ask. You kindly unmute your mic if anyone is having any query.
Sorry for interruption. One question remaining regarding hepatorenal failure. There is in chat box.
No, that I have already answered. That was the first question. If there are
Okay,
other,
okay.
uh, uh, I mean, apart from these three questions, if there are other more questions, you please ask. Get your ideas clear right now. I don't want anybody to be in confusion regarding as far as this aspect is covered, because many Ayurvedic person they are confused for whole of their life. I don't know for what reasons. If your study is perfect, you can address both the science very well. Your approach to both the science is very well. So
I think
bad some of the if bad prognostic indicators also, if there is persistent jaundice, unresolving ascites, there is coagulopathy, prothrombin time is increasing, low sodium, maybe because of dilutional hyponatremia, persistent hypoglycemia. These are the these are the signs which indicates bad prognosis in cirrhosis patient.
thank you so much, sir. I think there are no more queries.
Let's wait
Okay, sir.
before we come to the close, because in our setup पहले कौन पूछता है वो पूछता है वो स्टूडेंट्स का वैसा रहता है ना, वो
Okay,
उनको पूछना बहुत रहता है, बट पूछने में थोड़ा उनको हिचकिचाहट महसूस होती है. That's why.
yes, sir.
So how to interpret our concepts in our science in perspective of modern advances in medical literature? That is very important. And if you possess the sound knowledge of modern science, you can interpret those our concepts better in a scientific way, and you can explore those concepts in a very scientific way. So now everything is mentioned there. Now you see, even the hepatocellular carcinoma, because of this cirrhosis of liver, is also mentioned in our science. You go to the Yakrutudara, Pittudara, fast leading to Yakrutudara, and Yakrutudara, wherein there is Kacha irregular hard, Nabi irregular uh, hepatomegaly. In cirrhosis, although the liver shrinks and hepatomegaly you doesn't feel, but if there is a malignant transformation of the hepatic cells, then it grows like this hard and knobby, irregular, kacha prishtavat. And what is it? In 15 days, it leads to ascites. The complication is ascites. So there you can trace your science. The hepatocellular carcinoma is also mentioned.
Sir, there is one more question in the chat box from Dr. Bhargav Thakur. Sir, what is the role of vaccine in hepatitis according to Ayurveda?
According to vaccine.
Yes, sir.
Well, for you see this, uh, I think this question अच्छा है उनके दिमाग में आया है, बट ऐसा है कि हमारे यहाँ अल्कोहल का तो रोल बताया है सिरोसिस ऑफ लीवर में, इवन हेपेटाइटिस में, बट उस वक्त टेक्नोलॉजिकल एडवांसेस नहीं थे. उन्होंने यही उष्ण तीक्ष्ण आहार विहार इन केस ऑफ दिस पित्तज पैथोलॉजी, एंड इन केस ऑफ रुक्ष रुक्ष स्निग्ध आहार विहार, इन केस ऑफ कफज पैथोलॉजी, इन केस ऑफ शाकाश्रित कामला, they were mentioned, but they were not aware about the hepatophilic viruses. अगर वो अवेयर होते तो उन्होंने वैक्सीनेशन बताया होता, क्योंकि वैक्सीनेशन की कॉन्सेप्ट हमारे शास्त्र में है. मसूरिका में हम देखते हैं वहाँ का वो जो नीडल से नाक की जो मिकोजा है उसको खरोच के, या फिर ब्लिस्टर जो है वो ब्लिस्टर को खरोच के उसका वहाँ सॉरी ब्लिस्टर जो है मसूरिका का, उसमें का द्रव्य निकाल के उसको नाक के म्यूकोजा में लगाते हैं, ताकि वो स्लो सेंसिटाइजेशन हो, और वो एक प्रकार का वैक्सीनेशन ही था. बट अभी इनको हेपेटोफिलिक वायरसेस के बारे में पता नहीं था. जो बात नहीं है उसको फ्रीली एक्सेप्ट करना चाहिए कि देवर कि आचार्य वेर नोइंग एवरीथिंग, वो वाला अप्रोच छोड़ देना चाहिए. जो वास्तविकता है वो कबूल करनी चाहिए. वो नहीं था उनके पास, नहीं तो उन्होंने वैक्सीनेशन बताया होता. एंड वैक्सीनेशन इज गुड, एंड टाइम एंड अगेन इट हैज प्रूवन दैट because of the vaccination, the overall morbidity due to hepatitis B virus has come down drastically.
If anyone is having any doubt or query, feel free to ask. There is one more question, sir, from Dr. Parth Akini. Is there any direct role of sugarcane and chickpeas in liver cirrhosis? If yes, then which condition according to you, sir? Kindly enlighten.
ये इसका रोल नहीं है, शुगर केन का वगैरह कोई रोल नहीं है। बस अगर वो दूसरी बात इससे रिलेटेड मैं बताता हूँ। अभी ये स्टूडेंट है, जो क्वेश्चन, ये तो स्टूडेंट का क्वेश्चन है, इसलिए मैं उनको कुछ बोलूँगा नहीं। दूसरा ये है, जो अलर्ट रहने की हमें आवश्यकता है वो आज के युग में, क्योंकि हमारा खान-पान, रहन-सहन सब बदल गया है। पहले के लोग कहाँ ही कहीं पे भी जाते थे, पैदल जाते थे। अब पैदल नाम की चीज़ तो हम भूल ही गए हैं। यहाँ से वहाँ जाने के लिए भी हम बाइक यूज़ करते हैं। दिन भर बैठते, वही डॉक्टर कम्युनिटी खासकर, स्टूडेंट्स भी दिन भर बैठते हैं, टीचर भी दिन भर बैठते हैं। एनर्जी एक्सपेंडिचर होता ही नहीं है। जो खाते हैं बस उसका कैलोरीज बनते जाता है पेट के। और इंडियंस इंडियंस में तो टाइप ए पर्सनालिटी है, उनमें तो टेंडेंसी होती है टमी आने की। और वो लार्ज टमी, और उसके कारण ये ओबेसिटी के कारण अल्टीमेटली फैटी इन्फिल्ट्रेशन ऑफ द लीवर, ये एक पॉसिबिलिटी हमेशा रहती है। और उसके कारण भी ये एच जी ओ टी, एच जी पी टी सब बढ़ के वो डैमेज शुरू करके फिर दैट पेशेंट कैन आल्सो लैंड इन सिरोटिक कंडीशन। एक मेरे नाम नहीं लूँगा, बट मेरे सीनियर, मेरे से जस्ट एक बैच सीनियर थे। वो मोटे-मोटे ही रहते थे हमेशा, और शी वेंट इन सिरोसिस बिकॉज़ ऑफ फैटी, बहुत मोटापे के कारण। एंड अल्टीमेटली शी डाइड लास्ट ईयर बिकॉज़ ऑफ दैट। We need to stay alert from steatosis.
Please, anyone is having any doubt, clear in this session?
I can see my friends, Dr. Sachin Deva sir, Dr. Dailekar sir, madam. Are they?
We are having Professor Subhash sir.
I thought it will be better to have some interactive session and while explaining the thing, rather than putting the slides and just go on reading. That way, and anyway, that presentation also could not get uploaded. Yes. So yes, just this is what I want. Or I want my people to get benefited from my study and regarding this thing. And I want that they get their ideas clear once for and all. There should not, because whole of the faculty, Ayurvedic faculty is confusion. जैसे किसी ज्योतिषी के पास गए तो 10 ज्योतिषी 10 प्रकार का इंटरप्रिटेशन करते हैं। ऐसा नहीं होना चाहिए। कम से हमारा मेडिकल फैकल्टी है, तो 10 इंटरप्रिटेशन नहीं आनी चाहिए। यूनिफॉर्मिटी शुड बी देयर, कम टू द कंसेंसस। तो मेरे बुक्स है पेपर 1 और पेपर 2। खासकर पेपर 2 में मैंने डिसीज के संदर्भ में सब कुछ अपना पूरा ज्ञान, अभी तक का जो कुछ मैंने क्लिनिकल ज्ञान लिया है उसको, और आयुर्वेदिक थ्योरी को, उसको पूरे क्लिनिकल ज्ञान में उतार दिया है कि वो कौन सी चीज़ क्या है। वो ग्रहणी रहे, पांडु रहे, कामला रहे, सिरोसिस रहे, उसको प्लीज यू आस्क योर स्टूडेंट्स, पीजी स्टूडेंट्स पर्टिकुलरली, एंड यूजी स्टूडेंट्स, और पीजी यूजी स्टूडेंट्स आल्सो, बिकॉज बेस जो है वो पहले से स्टार्टिंग से क्लियर होना चाहिए। हमारे स्टूडेंट्स को एक थोड़ी सी अभी गंदी एक विकृति आ गई है कि कंसाइज स्टूडेंट किताबें पढ़ने की। जैसे शुरू से, अब उनका भी कोई दोष नहीं, उनको पहले से ही पढ़ाया जाता है। वो छोटी छोटी किताबों, पॉकेट साइज किताबों की तरफ उनका रुझान होता है। बट ये बताना जरूरी है उनको कि ये प्रोफेशनल कोर्स है। यू आर गोइंग टू प्ले विद द ह्यूमन मशीनरी। योर वन डिसीजन कैन क्योर द पेशेंट और लैंड द पेशेंट इन ट्रबल। So that's why you need to have the very sound knowledge of the subject. I see nowadays most of the UG students, they start preparing for the PG course in the UG course. They doesn't get the proper idea of the subject. They doesn't want to become a doctor. If they want to become a doctor in true sense, they must read. They must have a sound knowledge of the subject. By passing the examinations, you will become the only graduates only, not the doctors. Take it from me. So this is my message to all the students and my respected friends. Faculties are here. Sachin Deva sir, if he is here, we can have some interaction with Dailekar sir also, if he is here. and we can then finish off.
Now, I would like to welcome Dr. Shama Karekar, HOD, Yognidan Department, PIA, for the words of gratitude.
And thank you very much from my side also. I extend my sincere thanks to the entire team of Rognidana Department of Parul University for giving me a chance to interact with your students, and for giving RVPG a platform to honor the brilliant chaps in your PG Rognidana departments. Uh, uh, we would like to be associated with other institutes wherein this Rognidan PG is concerned, and we would like to felicitate under the banner of RVPJ to be promising young talents in Rognidana subjects. RVPJ is doing lot of things for the PG things, PG students. Recently, we launched International Journal of Diagnostics and Research, which is entirely dedicated to the Rognidana subject. And recently, we also launched the Rognidana Vikruti Vignana international publication, wherein the PG students they can contribute the book chapters, which carries 10 marks as per UGC. That thing is also there. For article also there are marks, and for at the in the very outside, as the Anne madam is has told our uh, activities in activities precisely what we are doing for our graduates and our teachers. We are constantly fighting with the body apex bodies for establishment of our subject with the state government, union government, and for the uniform pay structure as per the NCSM. So I request the PG students to join this organization in large number. Thank you very much once again.
Once again, thank you so much, sir. Thank you, ma'am. Thank you, all the respected viewers. I think we all enjoyed the session throughout. We are concluding the session. Namaste. Jai Hind.